All right. Well, I'm Frank Dumont. I'm an internal medicine physician, been practicing for over 26 years. I'm senior medical director here at Verta Health, and I have the privilege of being able to help moderate this conversation with this group of panelists discussing a very interesting and I think very timely topic with regard to the GLP-1s. We brought in experts for you from around the country with different perspectives, different backgrounds, which I think will really lend to a great conversation. I want to start out by introducing them briefly and then a few opening remarks, and then we'll dive right in. So first of all, joining us today is Kim Henriksen. She is the interim president at St. Louis University and St. Mary's Hospital, part of SSM Health. Previously, she was senior vice president of population health and clinical operations at Centene, and she's a registered nurse. Now, we're also joined today by Dr. Holly Lofton. She's an obesity medicine specialist and clinical associate professor of surgery and medicine at NYU Langone Health. She's also the director of their medical weight management program. We also have joining us today Dr. Alan Moses. He's an independent consultant for the pharmaceutical and biotech sector. Alan is trained in internal medicine and endocrinology, and he's the former chief medical officer for the Joslin Diabetes Center and former global chief medical officer of Novo Nordisk. And finally, but certainly not least, Dr. Derek Midlars. He's the Chief Medical Officer and Global Executive Director of Health Benefits and Services for GE Appliances. He's board certified in both preventative and occupational and environmental medicine. So again, as you can see, we brought together people with a variety of backgrounds, but a lot of experience in areas that are really pertinent to this conversation. Now, one thing I want to mention is that for simplicity, we've decided today when we're speaking about these newer classes of weight loss medications that are GLP-1-like medications, the incretin mimetics, we're going to be referring to them all as GLP-1s or GLP-1 agonists for simplicity. I understand that the environment is much more complicated. We have dual agents, we have triple agents that are coming out, but we're going to try to keep it simple and refer to them in general as GLP-1s or some variation on that. Now, just a couple of thoughts about where we've come over the last couple of years. So as I've thought about that, the first thing I would remark on is the fact that these medications have been available since 2005 commercially for the treatment of type 2 diabetes. But interestingly, it's really been over the last few years and the last couple of years in particular that they've really gained so much attention. So what we've seen over the last year is that attention not wane, but actually continue to grow, and especially in the setting of more and more data coming out with regard to their effectiveness. People are very excited about what these medicines could do and also what they can do for more conditions than simply diabetes and obesity. I say simply, but they're helping with other conditions as well. But one of the things that's happened with that is that we've also started to see over that period of time this need to address how we're using these medications perhaps more intentionally. Rather than simply being able to say these medicines are available, let's use them. We've reached a point where we've said we need to actually take a step back and decide how to use them well, partially because of cost, which has become a very important issue with regard to coverage of these medications, particularly considering how many people they might be applicable for. In addition to that, we're of course seeing the potential for side effects and complications of the medications. We always learn more about that as medicines are used more frequently. The other thing that I found rather interesting is because of the popularity of these medicines, there's been so much demand that it's actually outstripped the supply in some places, and we've seen people that need these medications for uncontrolled diabetes, for example, not even having access. So I think really that just tells us that there's a need to be able to take a step back and think about how we want to use these medicines well for all of the things that they can do, but do them in a way that makes sense, considering all of these many factors. So the last thing that I would say is, as I think about what's really become clear to me as I've pondered this issue more, how to use the GLP-1s and such, is that very little is actually clear. It's become clear to me that nothing is clear. And what that means to me is we need to learn, we need to listen to each other. And of course, that leads me then to our panel. That's why we brought together this group of experts to really help us dive into some facets of these areas so that we can have a robust discussion around it. So why don't we go ahead and dive right in? And I'm going to start out with a question that I'd like each of the members of the panel to address, which is really getting kind of the big picture on where we are with GLP-1s. These medications have been touted as being miracle drugs by some. We know that they can really help with things like weight loss, and they might very well help with other conditions, whether it's cardiovascular or renal or sleep apnea. But we also know that the cost has really become quite an issue in terms of employers being able to cover them and health plans. It was that a few years ago, these weren't even 10% of what was being spent on medications with organizations. But we're seeing this number go up double, sometimes even tripling year over year with regard to their use in both diabetes and also now in the weight loss space. And so the question is, Where do these medicines really fall? How do they stand up to the hype? And are they going to be doing more good for society, or are they actually going to break the bank? And so, Alan, with your experience and different perspectives in a couple of different positions, I'd like to start with you on that.
Sure. Well, first of all, Frank, I think you beautifully laid out the background for the challenges that we face with GLP-1, but also the hope for what it can provide in terms of improving outcomes, both for individual patients, but also at the societal level. We take for granted the effect of these drugs in diabetes, and I'm not going to speak much about that right now. What we've learned over the last decade is how efficacious they can be in terms of obesity and the comorbidities, most of which you've already laid out, that accompany obesity. So we're just beginning to see the advantages that these drugs provide, again, both for the individual and for the population, in such things as obstructive sleep apnea, congestive heart failure. Individualize the way these drugs are prescribed and the way people are followed when they are prescribed. They're potent medications. They have some side effects that can be generally well managed, but you also have to know how to start them and when to stop them and how to maintain the benefits that one has gained over time. And I think that's one of the great unknowns that you implied was present, but not yet resolved in terms of finding a solution.
Right. We still have a fair amount to learn. And I guess that's true with any medication class when they really become more commonly used. Holly, would you like to comment on your perspective?
One thing I will say that these medications have made my position as a weight management specialist a bit easier, not in getting approval for medication necessarily, but helping patients understand that we have viable options for them to seriously treat weight conditions without surgery. And I think this is very welcome to the population because there was this big gap between patients who could use diet and people who could get surgery and nothing in the middle that was considered to be effective. And the fact that these medications are helping those people who are in that gap, we're talking about BMI 25 to 35, understand that these hormonal treatments are helping them get long-term effects of decreasing weight and overall improving their quality of life. But I think the overarching picture here is it's helping to destigmatize obesity as a medical condition. And we know that this condition, obesity as well as overweight, affects about 73% of America. So why are we still stigmatizing the majority? And I think that this has created a revolution in science, in medicine, and I hope this continues. As we start to understand the benefits for the weight-related comorbidities, we'll start to see that treating weight is going to help many other conditions. And I think that's definitely a positive going forward.
So there were a couple of things that you said there that really resonated with me. One of them is that it's really changed the conversation that we're having with people that are struggling with weight. And I think that that's very much needed and overdue. The other thing is, as an internal medicine physician, I've always liked the idea of having a very full tool chest or tool belt, so to speak. And so one of the things that I heard from you is that in the spectrum of offerings that we have, this is actually helping to fill one of the gaps and giving you more tools and effective tools to work with. All right.
Absolutely.
So Derek, why don't we move on to you? Thoughts with regard to just overall impressions of where we are?
Sure, I have to agree with Alan and with Holly on many things they have said. From a employer perspective, I will say that certainly we know that these medications are effective and therefore need to be accounted for in a treatment paradigm of many patients potentially who struggle with obesity. But really, I think in the context of a comprehensive weight management program, to ensure that we get long-term results that we all seek. Certainly what we don't want to see is patients undertaking such a medication without appropriate guidance, stopping it for whatever reason, and regaining potentially any weight they might have lost in the short term. Certainly, I don't think we would find that clinically desirable, nor financially responsible in terms of health plan utilization management for these medications. And so I truly believe that a comprehensive approach needs to be the way we address utilization of these medications in order to really get the value that everybody wants from this novel therapy.
Yeah, I mean, there are a couple of aspects of that I think one of them is that it's been pretty clear in the drug trials that when people stop the medications and that we know from real world data that they often do, that they do regain the weight if they haven't made significant changes. The other thing, of course, we know is that the real world data are suggesting that people aren't having as much success as we had seen in the clinical trials. And I think that partially speaks then to that comprehensive care that was maybe being delivered in certain settings now, and certainly in the clinical trials, that just isn't happening routinely. Kim, what are your thoughts?
Yeah, my colleagues have expressed many of my thoughts as well, very effectively. While these drugs can be very clinically effective, and I do think they have created an opportunity for some who may not have in the past been able to address their obesity conditions, they do inherently come with some health equity challenges. We still have some access challenges for those who may not be able to afford it. They may not have the coverage. And I believe as a country, as Derek said, we need to continuously strive to improve health through a multi-pronged approach and multifaceted approach. So while the drug is one way to help, and sometimes it may be that kickstarting that weight loss, there's got to be this comprehensive program built around overall health and helping individuals throughout their health journey. Not everyone, again, has access because of the variability in coverage, the cost, and so forth. So I do believe as a country, we need to continue to address obesity. Obesity, as we know, has the long-term impact on a number of conditions, as Frank mentioned right at the beginning. So.
Well, and I know that this is a really important topic for you with your work that you've done with Centene in terms of the equity. We will come back to that. And so hold that thought. We're going to discuss that a little bit more later.
Frank,
yes.
is it okay if I interject here for just a second? Because
Please,
I think Tim and everybody has raised some really important points. We have to recognize for the people on this call and for prescribers that these drugs are to be used to treat medically important obesity. That is not cosmetic obesity, but obesity that is accompanied by the comorbidities that actually shorten life and increase the risk of hospitalization and expenditures associated with healthcare. And that requires that we intervene in a comprehensive manner, as been well pointed out. And one issue is when you start that comprehensive approach. We have failed miserably as a society in terms of preventing obesity, or indeed in intervening with obesity with standard measures of so-called lifestyle modification, because we tend, in many cases, to prescribe lifestyle modification without really prescribing something. We hand a patient a list of foods they should eat or shouldn't eat, how they should exercise, increase aerobic exercise, but we give them no incentive necessarily to follow that up. So we fail from the beginning. Yet, when done properly, that can assist the individual in terms of the weight loss achieved with the medication and provide a foundation for continued maintenance of weight loss once they've achieved their maximum for however long they're on the medication.
Yeah, I think those are great points about doing that much sooner in the process than we've been doing, and much better than we've been doing it. And I guess the one thing that I would add is that we know that not all lifestyle programs are created equal. That there are some of them that have been shown time and time again in study after study to be really hard for people to do long term. And yet when you really start to take advantage of the biochemistry and what we understand about weight and weight gain and why it occurs, there are ways that can really not only amplify the effect of the medication, but then help out with that sustainability you mentioned. All right, so we're going to move on and talk just a little about potential cost containment strategies. We've talked about just what some of the cost issues are with these medications. We know that there are organizations that have been really struggling through this and trying to decide what they should do in terms of wanting to help their people, but at the same time, again, not break the bank. So the question is, if we're looking toward a future where GLP-1 medications are not going away and are probably going to be even more frequently prescribed for more and more indications, how does one future-proof your organization for that? How do you actually prepare for that and try to handle things as reasonably fiscally as you can? So Derek and Kim, you in particular, you've both worked for organizations that have really taken some innovative approaches to how you're trying to deal with cardiometabolic health and trying to at the same time control costs, even as you're helping people be healthier. Maybe Derek, we'll start out with you in terms of some of your experience and thoughts.
Sure. I think for us, it is to ensuring that the right patient is on the right drug at the right time, for the right reasons, and with the right guidance. We've talked a lot about that. And so there are really two utilization management strategies that we've embraced. We started out with, a robust prior authorization and step therapy, but of course you have to leverage data to ensure that that process is discerning enough to ensure that what I said, that all the right things happen for the patient. And so, those considerations for the prior authorizations were to ensuring that we set a certain BMI threshold to ensure that actually patients participate actively and meaningfully in a comprehensive weight management program prior to gaining access to the medication through the health plan. And we set that bar at 6 months. Interestingly, we did this because we believe firmly that a lifestyle modification, a well-designed, to your point, Frank, not all of them are designed equally effectively. Well-designed program can actually help the patients lose a significant amount of weight. And if so, the question then becomes, do they really need a GLP-1 as part of that armament? If they're doing well for 6 months or so, through this comprehensive wealth management program. And certainly, it's also a requirement in our prior authorization that they continue with that program once they are on GLP-1, if that's what they choose to do. Also, they will have to demonstrate weight loss while on GLP-1 medication for obvious reasons. If you're not losing additional weight, there's no reason to continue the coverage. And all of these and then some provisions within the prior authorization, we made sure that we were requiring EMR level, medical record level verification, not just attestation by a clinician or clinician's office. Because as we all, I think we can agree here that those attestations do not always align with reality, if you know what I mean. And so that's one way, certainly. A second way, which we are actually pivoting to, I think, at the moment, or thinking about seriously, is having a gatekeeper as a trusted partner in this process, such as Virta, for example, that has proven clinical results in this space. And so whether you have one or two or three of them available through your health plan to the health plan members, we want to make sure that we predicate health plan coverage of the medication on meaningful engagement with such trusted partners. We think that approach is probably more effective because, again, not all providers in this space are created equal. And if you're discerning in that space and get the right partners to work with your population, you will see great outcomes. And certainly simpler in terms of administration, but also for the patients in terms of the process itself.
All right. Kim, what is your experience?
Yeah, similar. From a government payer perspective, the government oftentimes tells us what we should or can't approve. Medicaid is a little different than Medicare. And so prior auth programs are effective to some degree, but the GLP-1s are a topic in every health plan because the costs have just been going up and up and up. And the indications, as we noted earlier, are continuing to grow. And again, they're not without risk, and there is benefit. One of the challenges for payers is that the return on the investment of these GLP-1s takes time. And so having members in your system that are with you for a good amount of time, you can typically see that return on investment. But if you're a Medicaid payer, those Medicaid members turn over pretty rapidly, and you don't get the benefit of seeing that return on the investment in the improved health in your payer system, right? I mean, it may result somewhere else, which is great. But again, the key to success, I think Derek described it well, is comprehensive program, identifying partners who have proven success, and making sure that the right patients are selected at the right time for the medication, and then that there are programs built around them to support them through their journey.
Yeah, that makes a lot of sense. And I guess the one perspective that I would add from our experience here at Virta is when you're trying to find that trusted partner that you're working with, that not only helps you make sure the right people are ending up on the medication at the right time, but that has other facets of that support as well in terms of, having that effective alternative to medications, which might be a much lower cost alternative, being able to amplify the effect of the medication. We've touched on that a little bit, that the medicines work better when you couple them with effective lifestyle, and then also being that effective off-ramp that Dr. Moses was talking about, that when people come off of the medicines, having learned something and been supported in that such that you don't simply regain the weight.
Yeah, and it's not just when they come off, it's having a plan to help them get off, right, at some point. So,
excellent point.
yes.
All right. Well, so I'm going to change gears a little bit and go back to something that Holly, you had actually started to bring up, which is the way that we're maybe shifting the way that we're talking about and thinking about as a society, obesity. And it's a condition, the obesity and overweight is such a common concern, with the majority of the U.S. adult population being affected, that it's really a different way of dealing with and learning to think about chronic conditions. And so there's a bit of an opportunity here, I think, when we start to take a step back and say, what about other chronic conditions? What are we learning from our experience right now with dealing with metabolic health in our country and the use of these medications, which are effective, but which have potential challenges? What are we learning about not only how we could potentially be helping with chronic care conditions differently, but also how we're measuring our success? If you maybe could speak to your thoughts on that a bit.
One thing I think it's very important for the audience to know is that when you read the indication for all the GLP-1s and actually any anti-obesity medication, they are approved as an adjunct to lifestyle modification for the treatment of overweight or obesity. And when we talk about the perfect time for the patient, I think you mentioned that 6-month period is pretty critical, because if you look at diet and exercise alone, we can get great strides in many patients at 6 months. But 6 months also tends to be the point of inflection where we start to see weight regain, because that's the point where the body starts to fight back, increase hunger signals, decrease fullness signals, and the fat cell starts to become more stable. And that is the opposite of what the GLP-1s do for a patient. So that may be the time to actually really act, even if the patient has responded to diet and exercise. Because we look at long-term studies like Look Ahead, people did great for 6 months, even a year. 5 years down the line, they were all in the same place, independent of whether they were intensively managed with a dietitian, behaviorist, doctor, or if they did things on their own. And what we want to move the needle in thinking about obesity is that it is a hormonal disease, and the gland that is out of control is the fat cell. The fat cell is an inflammatory cell, and it leads to these other conditions like sleep apnea, like heart disease and diabetes, that people are more interested in treating because they're considered long-term conditions. And I find that when I'm prescribing a GLP-1, say for sleep apnea now, the patient says, well, I know I need this forever because my sleep apnea is there. But when I'm treating obesity, the patient says, well, what can happen when I stop this? Because my obesity is resolved. And we do need to shift the term that it's resolved so that it's in remission, because this is a condition that can come back, just like cancers can come back and diabetes can come back with things. So if we are interested in maintaining the patient off medication, it's important that that comprehensive and perhaps more intensive lifestyle modification be improved and initiated when they are coming down on the medication or titrating off.
So interestingly, one of the things that you're saying is actually kind of in the other direction, that you're feeling like in this area still, one of the things we really need to learn from with regard to management of obesity and treatment of obesity is still learning from what we know about other chronic conditions, that they're chronic treatments as well, that we need to think about it very much from the long term, as opposed to let's accomplish this over 2 years and then we're done. Alan, what are your thoughts with regard to the back and forth learning with regard to obesity and maybe other chronic conditions in our society that we're struggling with?
Well, obviously, the most interesting comparison is between obesity and diabetes. I mean, we know that obesity has fueled the diabetes epidemic. Even 6 or 7 years ago, when I was still at Novo Nordisk, we commissioned a study to look at how one could impact the diabetes epidemic by producing weight loss on a population level. And we found that to reduce the slope of increase of diabetes, to flatten that curve, you needed to achieve a 25% reduction in the incidence, or the prevalence rather, of obesity. Now, unfortunately, COVID sort of mucked things up a little bit, where we tended to gain more weight rather than lose weight during that several-year period. And that has thrown off those curves dramatically. And now it appears really that the most effective way to try to level off the prevalence of obesity is with these agents. So we're in this interesting situation where we want to limit the use of these medications from a cost perspective, but we want to increase the use of these medications from some of the chronic diseases that come from obesity. Now, I suppose in terms of other diseases that one could think about in terms of the downstream benefits would be hypertension and congestive heart failure, both chronic diseases that require chronic therapy. We know that GLP-1s as a class can improve both of those, reduce hypertension and actually potentially reduce the number of medications used to treat hypertension, as can weight loss from dietary lifestyle intervention as well. And the same is true now with congestive heart failure. So we're in an interesting situation where we have now efficacious drugs that are not only efficacious, but are proving to be effective on a population level if they're used properly and if they're used in conjunction with a lifestyle modification program that people can stick with, both while on the medication and most importantly, I think, while off the medication to maintain the gains that they have achieved during their use.
So, one of the things that I heard really clearly in this, and it's become, I think, apparent to a lot of people as they see the new indications for these medicines come out, is just how much overlap there is with these metabolic conditions, that they are related. And so when you start to address the physiology, because you're trying to address this particular aspect, you're probably addressing multiple aspects of health with a lot of the same interventions, whether it's lifestyle or whether it's an effective medication. The one thing,
if I can interrupt for just 1 second, that's certainly true for many of the comorbidities associated with obesity. Some seem to be purely weight related. Obstructive sleep apnea is a great example of that. The primary determinant of improvement in OSA is weight loss. Some of the other abnormalities, MASH, congestive heart failure perhaps, and others may also have other components, anti-inflammatory components that are part of the spectrum of activity of these drugs that are important as well. So it's an interesting mix, and we're still learning the science here to help us figure out how best to use these drugs, prescribe them, and follow them over time.
All right. Now, one of the other thoughts that I had, and again, this is just from my perspective of what we do here at Virta in terms of how we're thinking about how we can help people use these medications more effectively. That we're using a continuous remote care platform. And so one of the things that I get very excited about is as we wield that tool to try to really be available to people 7 days a week, coach, nurse, provider, that I wonder where that will be applicable in other areas of chronic health management as well. And so, that's another place that I'm fairly excited to see is not just what are we learning about how to use medicines well, but the tools that we're using to use medicines well might be applied in other areas of chronic conditions. All right, we're going to go back to something that Kim had brought up previously, which is the equity issue. We know that people that are in disadvantaged portions of our population struggle disproportionately with metabolic health issues. They struggle more with obesity, with diabetes, et cetera. Their outcomes are worse. Now, one of the things in this era of GLP-1s and the increased costs that we've seen, one of the things we've started to see is some entities saying, well, we need to do more cost sharing. We need to actually put more of the financial responsibility on the individuals. That's part of how we'll allow our company or our health plan to be able to afford to continue to provide these. But of course, that brings up the question of, well, then does that potentially compromise the ability for certain people that really need the medicines to access? So I want to come back to this question and see if you have any thoughts. And maybe we'll start out with you, Kim, as you had brought this up, and then move on to Derek. How do you make sure that the right people are getting these medications when they need to and dealing with some of the potential for actually amplifying equity issues in our healthcare system? Kim?
Yeah, thanks, Frank, for that question. I think it's one that I grapple with, frankly, but as I think about it from a government payer perspective, I do believe that increasing that a cost sharing type model and increasing the costs that would fall to the patient will limit who can access GLP-1s, and to your point, further divide and create that health equity gap. And it also is likely not the best way for us to be selecting the patients who can most benefit from it, and that's not in all cases, but oftentimes. So, thinking about how we address that, and that really is, Holly said this, start with the less invasive approach, get working with our patients and our members, and trying to ensure that they have full access to those lower cost strategies first, initially, and then identify those who get stuck or need that additional support. The other challenge is just from a payer perspective, again, particularly in the government payers, there is a limited amount of dollars that are available for the populations that they serve. And the GLP-1s, if they get out of control here, it could really reduce the dollars that are available to serve these members and care for some of the other conditions that are necessary that they be cared for. So I think it's important that we manage and balance the GLP-1s in a way that, again, getting to the right individuals, not just those who can pay for it out of pocket, and really being able to establish those comprehensive strategies that will be accessible to all.
So one of the things you said that was really interesting to me is it is not just about then who is able to get access to these medications for their particular condition, but it's the spend for these medications that, if it's not handled appropriately, if you're not trying to do this reasonably, that can actually compromise your ability to provide other care for other conditions for other individuals. So it's a much more global effect on your ability to provide care for some of the people who need it the most.
Yeah.
Derek, what are your thoughts?
I completely agree. As a employer who has a self-funded health plan, and we pay all the bills basically for all of the employees and their family members who are on our health plan, we struggle with all the same issues. This GLP-1s have, as you mentioned at the beginning, at the onset, have quadrupled in terms of utilization and cost, and it have become a significant part of what we think about in terms of what can we afford for our health plan members. And I think, again, choosing the right patients, giving them the right support, and then, and I think somebody has said that already, making sure that we follow them longitudinally, even when they get off the medication. They have invested a lot of time and effort in losing that weight. It behoves everybody, along the continuum of all the stakeholders, to ensure that these patients continue to have the appropriate guidance and the appropriate support, so that they can maintain, that weight loss that they have achieved. But there's no perfect solution, right? Folks struggle in the deductible phase of their insurance. Things get expensive, and even in the co-insurance phase, after they meet their deductible, it is not an insignificant spend for many patients, specifically for companies such as ours that have majority hourly employees. And so one way to address that in terms of the inequity issue is for us to offer programs like Virta. And the trusted partners who know how to do this well and have proven results over the long term, provide those highly effective alternatives to address not only the cost but also access issue. And I say that because we have patients, we have health plan members in rural areas, and they don't really have access to quality care. And so being able to provide a virtual program that anyone from anywhere can become a part of and partake in is super important for us. In addition to other solutions, I think the solution here is multifaceted. And so, yes, there are virtual options. We also have on-site primary care and behavioral health clinics with a registered dietitian at all of our major locations within the United States. And so those certainly partake in managing some of these patients and can become and have become our trusted partners as well.
Well, I certainly appreciate how much thought both of you have given to trying to address this very difficult issue. So I'm going to move on now to something that is maybe in some ways the most unfair question for the panel. And Holly and Alan, I'm going to prepare you. I'm going to throw this at you because I'm going to ask you to predict the future. We know that the metabolic crisis that we're dealing with in our country isn't going away. After decades of trying to address it, it's only gotten worse. We know that the GLP-1 medications have staying power. It appears, that we're not seeing any signals in the data to suggest that they're going to be removed from the market. And in fact, what we're seeing are more and more data coming out suggesting, in fact, other indications, other places where they could be helpful. So in a landscape where we think that there's going to be more need for these medications, more indications, and that the medicines are going to come out, and more variations, more medicines, including, the dual agents, triple agents, et cetera, we're going to have this be a part of the landscape going forward. What do you see in the next 3 to 4 years? And how do you actually think that employers and health plans can start to try to prepare themselves for that in 2025, considering all these things that we've talked about? Issues with regard to sustainability of using these medications, sustainability issues with regard to covering the cost, et cetera, but knowing that this is going to be an ongoing issue. So predicting the future, what can we expect and what should we do about it in 2025? And Holly, why don't we start with you this time?
I'll make my future prediction by giving you an analogy to the past. So I liken GLP-1s to cell phones and mobile phones. So if you think about 40 years ago, only people who had mobile phones were very rich, and the phones were about this big, and no one could afford them, and they didn't really work that well. Now, you mentioned, Frank, that we have been using GLP-1s for different conditions for about 20 years. So we are 20 years into using these medications, and the pipeline is picking up very quickly as to how many different options we have for patients, whether they're GLP-1s, dual agonists, triple agonists, other combinations, and non-incretin medications. So what that will hopefully lead to is a world where everyone has access to cell phones, as they do now, at different price points. So we will hopefully have more access to all, because we know medications drop off of patent. Other companies pick them up and lower the price. So I think this will shift the market into having some options for patients with different insurance plans, no insurance plans, and will take some of the stress off of you. Derek and Kim, I do not envy your positions in having to tell people why I have to do prior authorizations, as I'm sure you don't envy mine having to explain to the patient why their prior authorization was denied. So as we move forward, I do think we'll have a world where there is more equal access to care, because the market will open up with more options.
All right. Alan, your perspective.
Completely agree with Holly that we're going to see more of these agents coming out. It will be interesting to see if we can actually achieve agents that are more efficacious than the ones already available, or whether their advantages come from either a better side effect profile or their development in combination with programs like Berta as an example, that can show the long-term sustainability of the benefit one achieves from the drugs themselves. So I think that will be an interesting development over the next couple of years, and it's going to require the pharmaceutical companies, the biotechnology companies, to be smarter in terms of how they pursue the development program to achieve the maximum benefit. The other issue that I think is very important is that as physicians become wiser, and I hope they do, in terms of prescribing these medications, they need to know when to stop them. And they can stop, and this has already been said, but they should stop them if a patient is not responding. Now, why is the patient not responding? They can't afford to fill a prescription, so they're really not taking it. Or they're just a non-responder. Or 3, they're not following the lifestyle modifications that supplement the benefit, the pharmacologic benefit of the agents. Those individuals should not be on it, because that will help save costs. The distal end is just as important, and we've already talked about this. When you've achieved the weight loss, maximum weight loss at a year and a half, 2 years, you need to be on a program throughout this entire time that will allow that individual to sustain the benefits. The benefits are not just in terms of weight, but some of the other metabolic aspects of having taken the drug. Reduced blood pressure, improved heart failure, absence of diabetes, that is remission of type 2 diabetes if that's possible. Those benefits are going to accrue financial benefits to the payers. And I know we've talked a little bit about what the ROI is over a short period of time, as Kim referred to, and a longer period of time. And that is going to be a function of the payer system, which I suspect will continue to evolve from its current chaotic state in this country to something that may be a little more uniform, perhaps some of us hope.
Mm-hmm.
A lot of really interesting thoughts from both of you, and I guess the themes that I felt like I heard, three of the ones that came through pretty clearly to me are that there's going to be a larger variety of medications available, and we'll learn when to best use which ones. We'll also, I think, better learn. It sounds like from what you're saying, hopefully, when to use them and how to best use them across the board. So we'll be much better at implementing them and also coupling them with the right type of support when we need to. The cost issue is an interesting one because, of course, having more medications on the market for a longer period of time, we do expect the cost to go down. As an internal medicine doctor, I've seen this happen in a number of ways with other classes of medicines where they eventually started going generic and there was competition. I do wonder about some of the issues that are going to persist. Side effects with regard to the medications are still going to be something we have to grapple with the majority of people still stopping these medicines pretty quickly. But hopefully we can get better at that, as Alan was saying, helping actually support people and keep them on the medicines when it's appropriate. The other thing is, that this is something that we're seeing in just such a large number of people in the population that I think that's still something we have to grapple with. That if we're seeing the majority of adults in this US population on medications, even if we have better medicines, more variety of medicines, lower cost medicines, we've still got an issue we really need to deal with if the majority of the folks in the US need that kind of support and help. All right. So we're going to start to wrap up now. We've got just a few minutes left. And so I think I'd like to just come to some closing remarks from each of you, just parting thoughts. And so, one of the things we always hope when we're bringing a group together like this is that our audience can walk away with some ideas so that are really maybe a bit more actionable for them. So as you take a step back and you think about just, what we've talked about before or things that have been running through your mind, what things would you like to impart as parting action items or things to consider for our audience? And Alan, why don't we go ahead and start with you?
I'd say, first of all, learn from the results of clinical trials. And I don't mean the absolute weight loss, but the way individuals in the clinical trials have been able to stay on the medications for a prolonged period of time. That's a part of follow-up. It's a part of patient education, and it's a part of the gradual titration of this class of medications because of the GI side effects that are there. If clinicians just prescribe the drug to a patient without surrounding them with the lifestyle and the education they need, they're, I won't say doomed to failure, but they're going to see failure far more often than they need to and become discouraged themselves in terms of the utility of these agents.
All right, Holly, final thoughts?
What I would want to share is the sentiment I hear multiple times when I see patients about 20 times a day, and that is that this class of medication has changed their lives. They feel better, they can move through the world with ease, they can breathe better, they're off other medications, and they feel that they will live a longer life and live healthier. And one thing they tell me is they feel normal. So that means we have people walking around feeling abnormal. And if we can give them access to a medication that can help augment their lifestyle, to help them feel normal, that's really bringing something to the table for your employees, for constituents, if we're talking about legislation. And obesity is a disease that can relapse and remit. So if someone's regaining weight, it's not necessarily a failure, it's a time to escalate care. So we'll look at other strategies that can be available for them at that time. So offering a variety of treatments for obesity is definitely necessary because this is not a homogeneous condition.
Yeah, that's interesting. For all of us that have gone into healthcare to help people and to relieve suffering, this idea of actually helping people feel normal again is a pretty powerful one. All right, Derek, your thoughts?
Well, for all the reasons that we have all discussed here on this at this cast, moving to a trusted gatekeeper approach really makes the most sense because of the complexity of the treatment process that needs to occur for these medications to be highly valuable for the patient over the long term. And it's not only that, it's also ensuring that you define and you monitor through appropriate use of data the clinical outcomes that you seek and the meaningful engagement that needs to continue to occur over a long period of time for these folks to reach the success that we all see.
All right. And Kim, round us out here.
Yeah, thank you. I agree with my colleagues here. I think the GLP-1s have a very important role in addressing obesity. And they need to be used as part of a toolkit and not necessarily as the default. And we need to find ways for them to become more affordable and more accessible and be prescribed in the right hands. So lifestyle management and the comprehensive plan has got to be all a part of that.
All right. Well, I think that brings us to a close. I want to thank all of our panelists for taking the time and also just sharing with us their experience, their expertise, their perspectives. I know that our audience will be extremely appreciative as well. Thank you all so much.
Thank you.
Thank you, Frank.
Thanks.